Good evening, everyone. My name is Carver. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, The Day Keratoconus Stood Still, an upgraded manual for optometrists and ophthalmologists. You have a text box where you can enter questions. Please enter your questions at any time and we will discuss them at the end of tonight's webinar. We have two fantastic speakers tonight. Dr. Clark Chang is the Director of Specialty Contact Lenses and Corneal Services at Wills Eye Hospital in Philadelphia, USA, and part of the medical affairs team at Glaukos. He's additionally the host of the popular show, The Chang Reaction. He has been awarded the Top Doctor of the 2020 by the National Keratoconus Foundation, the 2021 Luminary Award for Distinguished Practice by American Optometric Association, and the Top 100 Doctor in 2022. With over a decade of research and experience in corneal cross-linking and other advanced keratoconus treatments, Dr. Chang publishes and lectures extensively in keratoconus management, modern contact lens technologies, and innovative refractive and corneal surgeries. Our second speaker is Dr. Jack S. Parker, MD, PhD. He is the only American trained surgeon trained at the world-famous Netherlands Institute of Innovative Ocular Surgery, NIIOS, in Rotterdam, Netherlands. He is recognized as one of the world's most famous authorities in the treatment of keratoconus and fuchs dystrophy, and is the author of hundreds of books and scientific articles on these and related conditions. Dr. Clark Chang, take it away.
Thank you very much, Carver. And thank you everybody for joining us today, and special thanks for my partner in crime, Dr. Jack Parker. And again, we took the, I'm sure many of you recognize the title and the parallel to the movie, The Day the Earth Stood Still, because we want everybody to come together and help to stop the aggression of keratoconus, sort of, very similar to the theme of the movie. And also to help us to celebrate and raise awareness for World Keratoconus Day, such as the ribbon that I'm wearing from a National Keratoconus Foundation. So any questions about that later on, certainly feel free to reach out to either myself or Dr. Parker. I just want to, this is this disclosure for Dr. Parker. This is for myself. Most of it already covered in our bio. So let's get this started. Traditionally, I think the reason why both he and I and Oculus believe that it's so important for us to take care of our keratoconus patient, partially because I believe that we have traditionally underestimated the impact of keratoconus to our patients' lives, and therefore the urgency to intervene sometimes may not be quite there. And so, for example, if you look at the CLEC study, multiple reports, huge amount of data following 1,209 patients across the span of about 8 years. It's pointed to the fact that the public health impact is very disproportional to the prevalence and clinical severity, meaning mild keratoconus patients can actually feel large amount of negative impact to their life regardless of their vision. So therefore, hopefully we're not only relying on our visual acuity or single visit data to determine how patient is doing. A separate report from CLEC study also demonstrated that keratoconus is associated with significantly impaired vision-related quality of life that continues to decline over the follow-up period, which is 7 to 8 years of span during the study. And you will remember, many of you will remember that majority of the patients, about 74% of patients actually already wear contact lenses at baseline. So this tells us again, no doubt that contact lens continues to be one of the best refractive or visual rehabilitation tool for us to manage our keratoconus patients. But that doesn't mean that just because we're maintaining the level of their vision, it doesn't mean that there's not negative impact from the disease, from this eye condition that is negatively impacting their life. So something to kind of think about. And potentially it's because of the increased anxiety and reactivity and how they're reacting to this stress as well as possibly just concerns of progression, disease progression when untreated or non-intervened, as well as frequent prescription changes, because in between changes, their vision is also blurry, which decreases the function of their daily life functions. And in fact, there are papers that points to the fact that keratoconus patients actually have lower scoring when they self-assess their life, the quality of their life, lower than that of macular degeneration, coming from CLEC study, and also other studies showing that also lower than diabetic retinopathy patients, including proliferative retinopathy, as well as vein occlusion. Just think about that for a second. The vein occlusion patients that I remember seeing in retina clinic, they are severely impaired, and yet, they are, there are publications pointing to the fact that they may do about the same or slightly better than keratoconus patients. So that brings about the fact that we need to, why are we underestimating the impact of the disease? Is it because maybe we need to redefine the disease or better understand the definition of the disease? So moving ahead to 2015 from CLEC study in 1998, there was a Delphi panel was put together, everybody thought it was about time to kind of talk about keratoconus to see, is there anything that we need to do differently? So they started out with defining the disease of what primary actinic diseases are in the 4 conditions that you see on the top of the screen, and separating that from your secondary thinning disorders like your Terrien's, marginal degeneration, and other conditions that you see listed towards the bottom of the screen. And what I think some of the really helpful pearls from this publication, which we're going to cover in the next few slides. One, I thought it was very insightful to come up with criteria that is fitting for the technologies that we have at that time, and that continues to be applicable, most of it, to today. And that is, they determine the clinical criteria mandatory to diagnose keratoconus as having presence of abnormal posterior elevation, as well as abnormal corneal thickness distribution. We'll touch up on that a little bit later, as well as the non-inflammatory corneal thinning. I want to point to the fact that the top 2, the posterior elevation being abnormal and corneal thickness distribution, is something that those are missing gap or missing data that we have from topography, which may be one of the reasons that, again, why we're underestimating the impact of the disease. And so they also pointed to the fact that, therefore, if in order to determine abnormality in posterior elevation, the most sensitive instrumentation that we have currently available continues to be your Scheimpflug technologies such as Pentacam, as well as other OCT technologies. And while we're on that point, I'm going to actually ask Dr. Parker a question. I always get asked with regard to looking at these 3 criteria to diagnose keratoconus, with specifically to the very last one, the non-inflammatory corneal thinning. There have been some publications that point to the fact that, obviously, whether it's because of thermolytic breakdown from eye rubbing that can be accompanied by inflammatory mediators on the ocular surface, or elevated level of MMP9 and other type of pro-inflammatory mediators found in keratoconus patients' tear film. How do you reconcile that with this specific criteria?
Well, first, let me say, Clark, really, it's just such a pleasure to be on a panel with you. I've looked up to you for such a long time. Just personally, you're such a smart guy, you're a personable person, and I just always enjoy being able to share any kind of forum with you. This is a great question. Is keratoconus an inflammatory disorder? My own mentor back in Holland, her name was Martine de Jager, and she is a Harvard and Bascom trained cornea specialist. She was the president of ARVO, and I asked her what was her most radical medical belief one time, and what she told me, she thought that all human ailments were inflammatory, that inflammation was the root cause of every medical problem. And that's obviously a radical belief, it's why I think it was a great answer. But I mean, obviously it's true that there's something going on that is degenerative. I mean, there is some sort of decay going on in the cornea, and it's not pure atrophy. I mean, these eyes are often irritable, at least subjective. The patients frequently do have inflammatory markers, which are elevated in their serum, even in their blood. The definition is meant to rule out cases of autoimmune ulcerative keratitis being conflated with keratoconus. That's the purpose of this distinction. So yeah, I think it's worthwhile having that distinction, but probably it is the case that people are rubbing their eyes with keratoconus for a reason. There's something that is not right and hot and irritable around the surface of the eye, and probably there is some inflammation there, regardless of how you choose to define it.
Right, that's a great answer. Thank you so much. We'll probably have to get you to start a new Delphi panel to redefine the disease at some point. And so the same publication then continues to give us more insight about not just diagnosing patients, but how do we do better at monitoring progression. And the 36 experts felt that we need to have two of the three following parameters being present, and that is progressive steepening of anterior corneal curvature, check, we could do that with topography. Progressive steepening of posterior corneal curvature, cannot do that with topography, and also progressive thinning or increase in the rate of corneal thickness changes to the distribution, meaning that we know that we know that all cornea, keratoconus or not, become thicker as it flattens out towards the periphery. So we, in contact lens terms, we call that sphericity, right? Or refractive technology terms. So basically, it's the change in that front surface sphericity is what they are talking about, and how we can, and we'll talk a little bit more about what test goes into that. I do think, though, for me, one of the most important takeaway from my point of view was that the panelists also agree that a change in both uncorrected visual acuity and best corrected visual acuity is not required to document progression. So again, think about that, because I think that's very important. We tend to diagnose disease, especially something like with keratoconus that has a profound refractive impact and visual impact. We tend to diagnose and also monitor using visual acuity. So potentially it's time that we need to have some sort of share weight with other metrics that we are using. Again, we'll talk a little bit more about that. So you may then think, but I only have topography, or maybe I have tomography at one location, but I mostly have topography in other locations. Is there something else that I could do to increase my sensitivity level in being able to identify abnormal cornea that may be keratoconic? So I think because Dr. Parker is going to talk a little bit about cross-linking and other procedures a little bit later, and the ability of being able to stabilize cornea or halt and slow the disease progression lets us sort of evolve the guideline of trying to detect as early as possible. So I think gone are the days that we wait for somebody to show with 50, 49, or 50 plus diopter in their steepest keratometry or Kmax or SIMK before we start thinking, well, that's not normal. We need to drop that threshold. So, here I'm listing some publications, some values such as, keratometry greater than 47 diopter, especially coupled with higher baseline astigmatism or frequent increase in refractive astigmatism or corneal astigmatism. Looking for asymmetry, we know that keratoconus does manifest asymmetry on both cornea and refractive attribute of our patients. So look for that, such as IS ratio, comparing the top portion of your cornea and the inferior portion of your cornea. But remember to decrease the intervals that we once used to think that we could wait for a long time to be actively managing our patient, because there wasn't really all that they had to choose was between glasses, contact lenses, and corneal transplant. Since we have many more different options now, we should try to we should titrate those intervals to be tighter for the benefit of our patients. And understand what limitations exist with topography or other less sensitive technology, so that we could try to compile these risk factors together in order to help you boost your ability to diagnose keratoconus patients if there is no access to OCT or your tomography like a Pentacam. So that's then take a quick look. I know we're all very knowledgeable about topography and the basic functions of tomography as well, so I won't dwell on these points. Obviously, your very basic format printout gives you not just topography, which is your upper left tile here. You could look for your IS ratio, you could look for your non-orthogonal presentations because of asymmetry, radial skews, and things like that. Here you can see that I marked I love the fact that they have the reticules here that you could look at. On the Pentacam, you could look at different diameter of capture up to 8 in this map printout, so that you could determine where the 6mm circle is for you to compute your IS ratio in the 5 different meridian if you so choose to. And then you have your elevation, front elevation, which is your top right, bottom right, your inferior elevation, as well as the thickness map that you could sort of mentally compile a distribution rate because there are multiple data points there. So I think those are all very useful. And the elevation values on front and back I've listed there for you, especially posterior elevation, because remember that's one of the criteria that was deemed as mandatory to diagnose keratoconus. So greater than 18 in a myopic patient or greater than 28 in a hyperopic patient can be suspicious. And so some of those things I think are, and I'm marking them here for you to see that where you can find those maximum elevation in a sort of, in a gross glance, and as well as the thinnest point and the decentration of it from where you think the geometric apex or geometric center would be, and also comparing interocular asymmetry can be very important. So remember, you could use all that in your basic printout. And however, and also, more asymmetry. This one I actually don't use as much, but I have worked with colleagues and surgeons who likes to compare the difference between either the central pachymetry to peripheral or superior and inferior. That's not something that I use as much, but I do want to point out that I have heard other people using it, which you can see you could spot those values very easily on the printout. But I think the versatility to me of a tomographer, such as Pentacam, is in the ever-evolving normative database and software that they come out with to help us manage our patients better. Obviously, that goes beyond just keratoconus patients, but I find it to be very powerful in managing my keratoconus patients. So we all know that the color printout is not absolute, right? It's really a relative comparison of the raw data to a reference sphere, meaning if you look at the peak of the triangle, because it's above the yellow reference line, so it's being regarded as either steeper on topography printout or your axial, your tangential, or more elevated on your elevation map. And then the sides of the triangle or any of the values below that reference sphere is then being deemed as being flatter in the axial and tangential map, or being deemed as being more sunken or less elevated when on the elevation maps. So why do I mention that? Because in order for us to be able to better detect especially mild keratoconus patients, that distance between the peak of the triangle and the base and the reference line is very important, right? If we could somehow enhance that distance relatively, so that there's more differential between the peak of the triangle and the yellow sphere, best sphere reference line, as I had denoted for you with the white arrow, the longer that distance is, the easier it is for us to be able to say, oh, that there is either definitive sign or that there's possibility for this cornea to be keratoconic. So how can we better do that with with Pentacam or a tomographer? So I would think that most of us would agree that in order to do that, the better way would be to drop the reference line, right? If you lower that yellow line, then the distance between the peak of the triangle and the yellow line is lengthened. So it's easier for us to spot where the extra elevations will be. So how do you reduce or lower that reference line? Well, if we remove some of the steeper values around the area of the apex in a keratoconic cornea, then you would, because those are the values that are mathematically skewing the best fit sphere value, right? So this software does something that's really useful, which is it removes about 3 to 4 millimeter area surrounding the thinnest point, because the thinnest point corresponds to the apex really well on most corneas, and also in keratoconic cornea. So if that's where they came up, Dr. Bellin and Dr. Ambrosio came up with this enhanced ectasia map, so you could see in the left half of the screen, and I'm moving it, separating it with my cursor here. You can see there are two maps or two columns of maps based on elevation. So on the top two, it's basically the elevation map in the first quad map or format printout. The middle row is your enhanced, meaning after removing that 3 to 4 millimeter. As you can see, it actually tells you that this enhanced map has excluded 3.5 millimeter area of value surrounding the thinnest point, and therefore you could see that there is a difference in the best fit sphere value. So you're lowering that best fit sphere, and in their normative database, they found that if it's a normal cornea, then that difference is not significantly changed, about 2 microns or so. But if it were keratoconic cornea, or other abnormal corneas actually, but much more so in keratoconic cornea, that value, removing that 3 to 4 millimeter area, can significantly drop the reference sphere so much that the elevation is enhanced to be much greater, in some cases 20 or more micron differences in elevation. And that's why you have this difference map here. So important to not look at the middle map, because it's being enhanced artificially by mathematical algorithm. So it's always going to look a little worse. You really want to just pay attention to the difference map at the bottom to see if it meets any type of standard deviation differences that's meaningful for you to think that this is an abnormal cornea. So they have they've given you the green, yellow, red, sort of your traditional stoplight, traffic light signal type of idea, where yellow is suspicious and red area are much more meaningful in that there's a deviation that's occurring in the difference map. So those are the things that you could look out for. You could also look at the progression, the sphericity changes on the cornea, and the vector differences in or decentration of the area of the apex. I don't use that one as much, I will say. I think what is really useful is looking at the pachymetry distribution map here in the CTSP and the PTI map. You can see the red curve, the red line denotes the cornea being scanned or measured, and the 3 dotted lines are the 2 bookends are the 2 standard deviations. So anything that dips below the 2 standard deviations tells you that the sphericity change is so significant that there must be some sort of thinning more central in the cornea that we may not have picked up from the first 4 maps. And if you say, well, that sounds interesting, and I'd like to see more examples, and I will definitely have more examples for you after this. If you say, that sounds like a lot of analysis. I thought software was going to make it a lot easier for me. Is there a single metric that I could look at that makes me at least tells me that something abnormal may be present, so I can look, I could kind of be a little more careful in examining all the data that I collected or to be collected on this patient. Then I would tell you that probably the best combination of specificities, the sensitivity and specificity in terms of denoting a normal cornea, most likely keratoconic, would be this final D value, this big D value that you see at the corner. And it's anything that's above, depending on the version of the data, the software that you have, if it's the version 3, anything above 3 standard deviation will be turned into a red color. As you see here, 4.39 deviation away from norm. And that's why the field is colored in red. So it tells you that something abnormal is occurring here. If that's, if you could only want to look at one single metric. And if you look at, I told you that there will be at least one more example of the looking at the global pachymetry or pachymetry distribution. You could see that the PTI graph, you could see the cornea is being measured in such a way that it's way below the 2 standard deviation. So it allows you to know that, well, there must be some sort of significant thinning within the central cornea that that is present. And something interesting to look at here is, for those of you who think, well, maybe I could just use my ultrasound probe. If you would have tried doing that, especially close to the area apex, you could see in the corneal thickness distribution map here that you probably will still get somewhere within the 500, 550. It's very difficult for us to actually visually just eyeball where the thinnest point is from the side profile without any magnification. So most of the time, you can see why single data point is not going to be our friend in diagnosing keratoconus patients. And so moving forward to, well, once you diagnose the patient, if we want to better at, if you're working with somebody like Dr. Parker, you're referring patients for him to, evaluate right away, or should you want to hold on to the patient for a short while and determine the rate of progression, how would you better do that? So the reverse of what I said earlier would be true, in that if we actually, because the area that is going to be most representative of the keratoconic nature of this the cornea that we're looking at, most of us would say, well, either it's at the apex or somewhere close to the apex of the cornea, right? So therefore, removing the value surrounding the thinnest point is not actually helpful. It's helpful for diagnosis, but not helpful for progression monitoring. So we should actually do the reverse, which is very smart. So if we actually exclude all the data, only put our focus in that central, again, 3-4 millimeters surrounding the thinnest area, then we will be able to take an average of that area. So no longer relying on one single data point, which is what some of the criticism has been, to rely only on, say, something like a Kmax or SIMK, because there's not enough data point there, no matter how sensitive that Kmax value can be. So here, with that new way of thinking, they have come up with this ABCD algorithm. A is your anterior curvature in the 3 millimeter zone. B is the 3 millimeter zone, and I think I did say 3 to 4. I meant 3 millimeter for the ABCD. I apologize for that. So B is your PRC, which is your posterior curvature, looking at the 3 millimeter zone and many data points within that zone, as well as your pachymetry of the thinnest location. And most of us, should do better at entering the data for vision, but I know a lot of clinics don't actually enter that, but that's okay. We still have 3 different metrics to look at if you happen to not enter your D value. So the longer the bar, the more severe, the higher the staging in the severity of the disease. And so you could see that not only is each serial visit color coded, so visually it's very easy to look to see, to get a global view of what's changing. And I also find it very helpful that they have these statistical gates that tells you if should any change be present, how statistically significant that is. So you can see that the red gates are are drawn from the normative database for keratoconic corneas. So if it meets 80% confidence interval of change or 95%. And so I find that to be very helpful. And in my example of a patient from Will's eye, you can see that the posterior elevation has changed, meeting the 95% statistical value, as well as the amount of thinning. But yet, if we would have only relied on anterior metric, whether it's topography or any other instrument, and looking at only Kmax, you'll notice that over the 3 visits, really very little has changed because of the fluctuation. Any irregular cornea is not going to be exactly the same every single visit. So that's where it's important to rely on more averaging of a zonal area rather than a single data point. So for that reason, I find ABCD to be very helpful. And you may be thinking, well, you know, I don't know that what would happen if I don't have these advanced instrument? Are my patients basically just not, they're not, I'm not able to diagnose my patients or monitor them for progression? I think if you look at this paper, well, technology is definitely very important. I think there are ways where you could connect and network with surgeons like, say, Dr. Parker, who you could refer, and then he could, if you only have topography and you need tomography such as a Pentacam, he has it in his clinic and he can do it for your patient. So there are definitely ways around that for communal sharing of resources. But if you look at this paper from Karina Kopen's group from Belgium, you'll see that despite having access to advanced technology, still only about 70% of patients are 70% of patients are already reaching about stage 2 using the classic AK scale. So early, moderate, stage 2, 70% of the patients at the time of being diagnosed keratoconic. So that tells me that there's still that human factor of knowing when to pull the trigger to order imaging. So I think that's where we come in. We need to be mindful of what the patient's quality of vision complaints and their small increases in their refractive attribute, family history, eye rubbing, all that type of thing. And, in order for us to kind of clue in that there's something more that we need to do. And I know that you may also think, well, we're so good at maintaining our patient's vision. Yes, I hear that you said visual acuity may not completely indicate or reflect how the patient is doing in their life, but undoubtedly we could do really well by them with all the contact lens advancements that we have, whether it's scleral lenses or other lenses. And I would say, that part of that is true. But looking at this 42-year-old patient case from Dr. Jeff Sansino, who due to cost and other reason, and I believe this was actually around the time or before the time that it was maybe a little after in 2016, 2017 when cross-linking was first FDA approved. Due to cost barriers, patient can only do either contact lens fitting or cross-linking, and patient chose to contact lens fitting because also he is in his 40s, so most of us would think we could watch the patient for a little bit longer. Well, 5 months later, this is what happened to this patient. Patient was not uncomfortable because we're so good at fitting contact lenses. We're already taking some of the abilities that patient can report potential progressions to us, whether it's by vision or the comfort level of their lenses, right? It used to be with RGP, there's very little forgiveness to corneal progression. They'll come back to you, they'll tell you that the lenses are not as comfortable. With newer lenses like hybrid scleral lenses and other technologies, we've taken away their ability to say, hey, I'm not comfortable, maybe something changed. And within 5 months, you could see that the amount of tear lens has dissipated, and that is nearly 400 micron of space that have been eroded due to progression of keratoconus. So I think we really need to learn to embrace this interdisciplinary collaboration with surgeons like Dr. Parker to better deliver care to our patients. Because if we could combine ability to halt and slow progression and maybe other procedures that Dr. Parker is going to cover a little bit later, and then when we have the patients back, we could always reserve the ability to refit them or refit them in contact lenses to maximize the quality of their vision. So I think that is what we really need to do, especially on this World Keratoconus Day. So Dr. Parker, I'm going to pass the mic back to you and have you cover these slides for me, please.
Oh, thank you very much, Clark. I mean, I think all of that was brilliantly said, and frankly, it's the most important part of the whole discussion. I mean, the treatment paradigm for keratoconus is so well established. The treatments are so much better than they used to be. It's abundantly clear what needs to be done now. The tricky part is making the diagnosis, actually. And the cornea specialist is the least likely person to make the diagnosis, because you don't get to the cornea specialist until someone's figured out what's going on. Nobody comes to me and they're a mystery and maybe it's keratoconus. Everyone comes to me because they've already been figured out by someone smart out there looking for the problem. So when they're sent to me, I do the easy thing. And, well, as you see here on the screen, one of the very easiest no-brainer things to do is this procedure called corneal cross-linking. It was described basically 20 years ago, but basically everything in medicine is on a 20-year delay. We have a very conservative profession that's probably good in ways that we're not constantly rolling out radical new treatments and having them go bust. But at the same time, it means you have ideas which are proven to be effective, and it's 20 years before they typically catch on the community. And one of these things, which is just now catching on, is corneal cross-linking. So corneal cross-linking is an in-office procedure. It does not involve surgery. It involves really debriding the corneal epithelium and dripping a riboflavin solution over the cornea for an hour while the patient stares at a UV light for 30 minutes. What I tell my patients who are having the procedure is that this is not exciting. You're all keyed up for an operation. This is boring. Half the people who have the procedure fall asleep in the office. So really, it's a dull, unexcited, sort of emotionally let down day when you come into the clinic and you stare at a light and have eye drops for an hour and go home. The recovery period after cross-linking, the eye is typically itchy and scratchy for about a week or so. We typically tell patients to use an antibiotic steroid combination drop for a week or so. And then after that, most people are more or less back to their baseline. I think that one very important thing to keep in mind about corneal cross-linking is corneal cross-linking does not reverse the progression of keratoconus. It doesn't remodel the cornea in some sort of reconstructive way. The analogy that I use for my patients is that corneal cross-linking is like calling the fire department. The fire department will rush out and they'll put the fire out, but they don't rebuild the house. They don't buy you new furniture. Whatever is done, and the fire department just prevents further loss. And likewise with cross-linking. Cross-linking is extremely effective at stopping the progression of disease. And that's why it's important to cross-link people when they are as near as normal as possible. Obviously, if the eye is 20/20, that's the condition in which you'd like to keep it, or 20/25 or 20/30. By the time the patient is 2400, it's not that cross-linking is less useful, but the purpose of it is to prevent the patient from getting to 2040 or 2400. It's to keep the horse in the barn. Now, I will say that as a corneal transplant surgeon, really the bane of my existence is to do corneal transplants on patients with keratoconus. I think a corneal transplant is a brutal operation for somebody, typically a young person who rubs their eyes. And often, our keratoconic patients are not the best historians or not the most compliant, or maybe they just got young and active lifestyles and better things to do than come to the doctor. So you really want to avoid a transplant in these people. And that really is the point of cross-linking. It's to try to prevent the need for a corneal transplant in the future.
And Dr. Parker, I also want to say that, again, you and I receive these type of questions all the time, such as, is there a point that's maybe too early for my keratoconus patients to be considered evaluation for cross-linking, or maybe is there a point on the flip side that's too late? So if you look at the the Penthier publication, and there's more than one publication that points to this, and that is the visual quality or visual related quality of life can actually be beneficial from treatment of cross-linking across all stages of keratoconus, as long as they are, can safely undergo the procedure. So I do think that sort of echoes what you had said a moment ago, which is it's a no-brainer, and a lot of a lot of patients are maybe not being considered due to sometimes just misunderstanding of what cross-linking can do for them, because they think it's like corneal transplant where somehow they're magically reversing the course of their keratoconus journey. And unfortunately, that's obviously not the goal of corneal cross-linking.
What I would echo that statement. I think, is there a point at which cross-linking, it's too late for cross-linking? Yeah, probably, but I think that point is probably later than you think. I'm a huge believer in scleral lenses. There are people in our practice who have Kmaxes in the triple digits, who are 20/40 in a scleral contact lens. So seeing those patients roll in with unbelievably good vision wearing a contact has really made me a believer that there is very low indication for a corneal transplant unless you've got dense central scarring. Just steepness alone is hardly an indication for a transplant. So if you've got somebody with advanced keratoconus but no central scar, that is somebody that's worth trying to make sure they don't develop a central scar. That's someone you really would still think cross-linking could help them. And likewise, on the flip side of the spectrum, I would just say for the very, very early patients, the ones that you diagnose at stage 1 or stage 0, and you're very, very suspicious of them, I don't think that cross-linking can be meted out indiscriminately. It's not a vitamin, it's a medical procedure. There is no medical treatment with effects that doesn't have the potential for side effects. You can certainly hurt somebody with cross-linking. You definitely can, just like you can hurt somebody with cataract surgery or any of the other things that we do. But I think the risk profile suggests that we're not cross-linking people enough and early enough, rather than we're doing that too much.
Right, and to that end, you and Dr. Dockery and a group of authors actually looked at 514 eyes in your practice, trying to determine if there's a point that's maybe too late, or if there's a difference in outcome pending different risk factors that we tend to exclude keratoconus patients from further consideration of other treatment. And so I'm going to play this video because Dr. Dockery, I think, does much better justice than I can to your study finding.
Yeah, me too.
I'm going to roll that video for everybody.
Uses riboflavin combined with ultraviolet light to strengthen the cornea of patients with keratoconus. The goal isn't necessarily to improve vision, but to halt progression of disease. But how effective is it? A new paper titled Corneal Cross-Linking of 514 Eyes with Progressive Keratoconus is a retrospective analysis assessing the effectiveness of stabilizing the cornea and preventing the need of further treatment, such as repeat cross-linking or corneal transplantation. What we found is that after cross-linking, there were no clinically significant changes in corrected distance visual acuity or any corneal tomographic parameters. Corneal cross-linking did, however, halt progression of keratoconus. At 1 year, 97% of eyes, and at 2 years, 90% of eyes needed no further treatment to maintain stability. This cohort of eyes consisted not only of patients with mild to moderate keratoconus, but also with very advanced disease, including those with a Kmax greater than 70 diopters. In this very advanced group, rates of treatment success were significantly worse. But while some literature suggests that cross-linking may not be as effective in eyes with a Kmax greater than 58 diopters, this study shows that that threshold may be even higher because all patients with a Kmax under 70 diopters seem to have equivalent outcomes. Moreover, of the patients that needed further treatment, all but one were successfully managed with a single application of repeat cross-linking, meaning that only one patient needed corneal transplantation, and at that, it was a DAUC, not even a PK. So all patients were able to maintain their native endothelium. Overall, corneal cross-linking is a fantastic procedure that predictably induces corneal stability and is a viable option for all stages of keratoconus. But because it may not be as effective in patients with very advanced disease, detecting keratoconus early and cross-linking early may be the biggest key to treatment success.
Yeah, that's really well said. And so you had touched a little bit up on your postoperative monitoring protocol. Would you mind talking to us a little bit more about that?
I think the key thing is that cross-linking, the FDA-approved version, does involve creating a 9mm corneal epithelial defect. And that epithelium typically heals in quickly. You know, we're talking about young people here, but for at least the first few days, you have a risk in which there's the potential for infection. So these patients really need to be monitored, I think, carefully for the first week or so to make sure that you're not developing a corneal ulcer. That's one of the worst things that can happen. You take a young person with good vision, you're trying to protect them from developing corneal scarring, and you give them an infectious central corneal scar. So I would say that if you treat somebody with a bandage contact lens, then you should be really careful. It's not mandatory. You know, you can just use a pressure patch instead of placing a contact, which may reduce the risk of an infectious keratitis. I think the contact should be removed as soon as practically possible. And somebody should be treated with an antibiotic while they're in the healing phase, whether they have a contact lens in or not. Usually what I tell patients is that for the first month after you're cross-linking, you're going to be wondering, what have I done? Oh my God, I'm so much worse. Your vision is worse. All of the measured parameters of the cornea are worse. The cornea is thinner. The cornea is steeper. The vision is worse. It's hazier at the slit lamp. And this really is the, I would say, remodeling phase of the postoperative period. What I tell my patients is, imagine you paid somebody to come in and remodel your house. And a week into the job, you walk in and it looks like your normal house. You say, well, what are you bums doing? You know, what am I paying you for? You know, you want to see ripped up floorboards and dangling wires and exposed pipes. You know, you want to see evidence of men at work. And the first month of cross-linking is the men at work phase. And it's actually a positive prognostic sign when you see these things. It's the patients that are overly happy that you worry about, that you worry that maybe you didn't give them the full treatment somehow. After that month or so, though, the cornea has to a great extent remodeled, and you can start talking about refitting somebody in a glasses or contact lens prescription. At least that's my experience. But Clark, really, you do all of that work. I'd be interested to hear what you think.
Yeah, I completely agree with that. There are even reports of improved and more than what you think, short-term neurotrophic effect from an corneal surgery or any ocular surgery would provide. So their reports showing improved contact lens fitting appearances, contact lens comfort and tolerance afterwards, longer than what you think, if it were just due to some sort of temporary neurotrophic effect. So all that I, do want to tell our colleagues is that we certainly, from a typical epithelial healing phase, as long as there's no history of some sort of delay healing or maybe some issues that you think the epithelium is going to slough off, obviously you may have to adjust your contact lens fitting accordingly. Sometimes you get people with really pretty extreme flattening in their topography, which is good in a way, but that may actually also lead to a little more frequent lens exchanges. I used to make my patient wait for 3 months, and realizing that there's no reason why we couldn't start earlier, actually are now and have been for years actually evaluating refitting contact lenses in my patients about as early as 3 to 4 weeks, provided there is no other contraindication. And again, because we're fitting them in contact lenses and their vision typically is maintained at a very high level, so they are not able to give us any type of feedback in the long run. I'm not talking about the initial 6, 12 months, 2 years. As you can see from the paper by Dr. Parker and Dr. Dockery, that there's a small group of patients that may continue to progress. So I love the fact that we could use the ABCD software. Again, they have this new new ability to give you to monitor for post cross-linking potential progression using these blue gates. But Dr. Parker, there are times that patients desire something else, and I know that you're an innovator that always try to figure out what the patient needs the most, and you have other procedures that you usually offer these patients. Can you talk to us a little bit more about what you do?
Well, the greatest fortune in my life really is actually to have been around innovators. I myself am a hanger-on, and some of the great innovators that I've been around include this wonderful, incredibly talented ophthalmologist in India, Susan Jacob, who's described a new technique for treating keratoconus. You know, this is a case example that you have on the screen of a young man who presented to my clinic. He was complaining of blurry vision, referred by his optometrist. Yes, obviously the diagnosis is keratoconus from the Pentacam. Yes, obviously this person needs to be cross-linked, but that's not why he came to see me. He didn't want to get cross-linked. He wanted to know what could be done to improve his vision. And you know, the problem with the vision is that bulge on the cornea. Intacts were described some time ago, and they are a logical solution. You place them in the cornea, you localize them to the area of the bulge, and the intact flattens the cornea down into a more normal conformation. The problem with intacts, though, is that not everybody is a candidate for them. If your cornea is too thin or too thick, you can get erosion of the segments out through the top of the cornea. What I tell my patients is it's kind of like you heard the story of Grandpa the moonshiner was shot in the butt 50 years ago, and the bullet has slowly worked its way to the surface. That's the way these segments can be. They can come out of the eye if the patient rubs their eye. Not to mention, you can get dysphotopsias. You can get glare from these segments in the cornea, which are always noticeable and sometimes bothersome. But really the greatest drawback of the intacts is they make a modest difference because you can implant them in a mild to moderate cone. They typically make a mild to moderate effect on the shape of the cornea, typically equivalent to about 2 lines. So this brilliant ophthalmologist, Susan Jacob, had the idea of improving the intacts operation by addressing all of these perceived limitations. So I tell people this is intacts version 2.0. This is the exact same operation, exactly the same, except the segments aren't made out of plastic. They're made out of collagen. They're actually made out of donor human corneal stroma. And you might say, well, why use cornea if you can use an artificial material? Well, there are several reasons. First, you can use a much thicker piece of collagen than you can use plastic because you're not worried about erosion. These are made of the same material as the patient's cornea, so there's no tendency for the body to spit them out. So you can use a big, thick segment and you can place it up high in the cornea where it achieves drastic effects on the shape of the cornea. They also don't glisten or glint. You get no glare from them. You get no dysphotopsias. And as a result, the patient's subjective experience with them is better, particularly because these bigger segments achieve much greater flattening. So CARES gives you better quality vision and much more substantial corneal flattening than intacts, while being probably a safer operation. There's a video here that is also narrated by our brilliant protege, Philip Dockery. And Clark, if you want to play it, that'd be great.
Yes, no problem.
Prior to the implantation of the segments, manual CARES implantation and manual intacts implantation are strikingly similar. After measuring the corneal thickness at the location of the upcoming temporal incision, we mark the cornea to guide us with the implantation of the segments. We then set the guarded diamond blade to 60% of the previously measured thickness and make the first radial incision. After applying suction to stabilize the eye, a pocketing hook is inserted in the radial groove and rotated to dissect a 1 millimeter space on either side. A corneal separator is inserted into the stromal pocket and gently rotated to bluntly dissect a channel for segment implantation. This is repeated in both directions from the temporal incision. Unlike intacts implantation, a second incision is needed along the nasal margin of the channels, so we set the diamond blade to 100 microns deeper than we did for the first incision, so that we can ensure communication with each of the channels. A Sinskey hook is then used to verify this communication. Prior to the start of the operation, each of the segments is stained with trypan blue and laid flat on a Wexel sponge to dehydrate. At this point in the surgery, we dry the ocular surface and peel a segment from the WEC. The segment is then placed atop the recipient cornea and pushed into the interstromal channel through the temporal incision using a bent Y rod. Take note of the vivid contrast between the stained segment and the recipient cornea and how that differs from the surgery done with unstained segments. Furthermore, the dehydration of the segments allows for easier implantation of thicker segments, which induces a greater degree of flattening than thinner segments. Notice how the dehydration of the segments improves visibility as well. After the segment has been advanced through 50% of the channel by pushing, a reverse Sinskey hook is introduced via the nasal incision and used to pull the segments to their final location. This process is repeated on the opposite side if a second segment needs to be inserted.
So I'm gonna roll it forward a little bit more for everybody.
Yeah, please.
The extreme flattening effect the segments induce. So if needed, we'll then use a 10-0 nylon suture to close both incisions and complete the operation.
Yeah, I think you could probably go ahead and we can show the result of this case. We probably have a few that we can show. This is the patient at issue here. You can see they had 13 diopters of flattening, so that's much more than you get with an intact segment, for instance. You can see how appropriate the treatment was. You know, the whole cornea is not globally 13 diopters. It really is just kissed exactly where it needs to be. And I think we have a few more examples here we can show, probably, Clark, if you want to move ahead. And we may even just go quick. So here's another example. This is an eye that had very advanced keratoconus that had 2 care segments placed. I did 2 CARES operations today on patients who had Kmaxes greater than 80 diopters. So it's a great operation that you would never use for intacts, and is transplantation sparing. It's transplant avoiding.
And if I could just point out that Dr. Parker, not you, because you're probably too humble to mention it. So not only is you see this significant curvature changing effect, I know a lot of our contact lens specialist colleagues in the audience may think, well, but normally that doesn't really change my, doesn't improve my contact lens fitting or patient's contact lens fitting experience. If you look at the Scheimpflug image of the 2 eyes side by side, you see the amount of sagittal height difference that was produced postoperatively, proving that patient can possibly have an easier time with contact lens fitting, because that elevation, that focalized elevation, really does change from treatments such as this one that Dr. Parker performed. I'm sorry for hijacking the mic.
No, that's exactly right. One of the CARES cases that I did today actually was a patient that had flown in from Texas who was scleral contact lens intolerant in one of his eyes. So the purpose of the CARES treatment was to restore his contact lens tolerance. So that's the whole goal. Yeah. Shall we just go quickly here? This is a patient with moderate keratoconus. You can see it still corrects pretty well to pretty good vision. So naturally, this is a new diagnosis. So he's treated with cross-linking. After that, we tried to improve his vision by implanting one of these CARES segments. You can see he had 6 diopters of flattening inferiorly, but still with a pretty big prescription. You know, he still has 4 diopters of cylinder. So the question is anything can be done to improve the vision beyond this? You know, he's been cross-linked, he's had his CARES implantation. Well, what else can be done? So we actually implanted ICLs in him. So this really is the triple whammy. You can see in this little inset box, and we probably don't have time to watch the whole video, but you can see here, this is an eye about to undergo EVO ICL implantation. He's got a CARES segment inferiorly in the cornea. You can kind of see it there on the left. And here the ICL is being put in. And the bottom line is this is somebody who had really very severe visual limitations, blurry vision that was getting worse, you know, from a progressive eye disease, keratoconus, And not only has the course of his disease been arrested, but now he's been restored to 20/20 uncorrected vision as a result of a combination of these therapies. So yeah, I think we probably can move on. This is a really quick case. This is an eye that has, of course, very advanced keratoconus. This is an eye with corneal hydrops, with splitting of the back of the cornea. That's what's going on. Corneal hydrops heals very slowly over a long period of time. It's got these intrastromal fluid clefts you can see on OCT. Interestingly, these lend themselves to mechanical repair, these holes in the cornea. You can sew them up with sutures in the operating room. That's what Clark is showing here, just a few simple sutures placed in the cornea. So this eye with hydrops, the day after the procedure, we got some comparative OCTs that show what the cornea looks like before suturing and then after suturing. Clark, I think you probably can show those too. There's the before and there's the after. And the vision went from hand motion pre-op to 2150 one day after. So this is obviously a much better solution than just allowing someone to sit around with hydrops for 6 months or a year or so. So even here, even when you have such a terribly destroyed cornea, even here, you're thinking to try to avoid corneal transplantation.
So Dr. Parker, from the OCT, I believe the OCT at the bottom is actually day 1, not 3 months. Am I correct?
Oh yeah, that's 1 day post-op. That's right.
Yeah. So you can see how much that compression is definitely, forcing the fluid to actually leave cornea, which is what we want to do. I've actually also heard Karina Copen talk about her procedure with compression sutures, but I never had the chance to ask her about, do you have specific patient selection criteria of those that you may just, knowing that it may take a few months, I don't know, maybe they're not in a rush to get back to their convalescence. Do you do this on everyone with hydrops, or do you have some sort of specific selection criteria for these people? And when do you remove the sutures?
Well, keratoconus, the more you know about the disease, the more you realize you don't know anything about the disease. Characteristically, it's described as the disease of the anterior cornea. That's probably not only wrong, but exactly backwards. As you said in the beginning of your talk, Clark, you can't even have keratoconus unless you have posterior corneal abnormalities. That's required. So keratoconus may actually be a disease of the back of the cornea rather than the front of the cornea, which is mind-blowing. There are often patients who have horrific hydrops, and they'll keep it for a year or 2 years or so. A year after the insult, you see them in your office, and they've got corneal edema. They're feeling better, but they've got corneal edema a year after. Other patients, you'll see they have hydrops, and a month later, it's gone, okay? So I've signed people up for compression sutures before, taken them to the operating room, and on the operating room table, it's gone, okay? So there are definitely people that I have jumped the gun on and been too zealous to operate on. On the other hand, I think that basically the alternative is a corneal transplant. This is a very low risk thing, putting a few sutures in the cornea. So there are no people that I think are poor candidates for this. Usually I start to remove the stitches when they're loose, or I begin to pick them out as the patient heals, usually 6 weeks, 2 months after the operation.
Great. And is there ever any cases where these sutures may leave, although may not coincide with visual axis, but sort of you see sutures at the junction of, say, a corneal transplant, and
oh yeah, absolutely. You can get scarring. In fact, frequently you do get scarring, and sometimes that scarring does affect the visual axis indeed. But still, that scarring is typically better than the vascular scar they would have developed if you'd allowed the corneal hydrops to remain there for 6 months or so. So typically, I think it's a technique for reducing scarring as opposed to engendering it.
That's great. So that's the end of our lectures. And I just want everybody, thank you for being here as well as being part of the movement to support World Keratoconus Day. Here's our emails. We did at Glaucos, we actually took a photo to go on social media to kind of let keratoconus patients know that we're with them, we support them. And hopefully you have done the same today, or maybe next year that you could take a photo with your staff or students who rotate through your clinic and help us promote the awareness for World Keratoconus Day on November 10th. I'm gonna throw the mic back at Carver, and let us know if we should do a few minutes of Q&A or if there's anything else that he wants to close up with.
Absolutely. I mean, it's always so great to have you all present for World Keratoconus Day, and just learning about the most relevant and newest techniques like CARES, and just kind of the procedures for diagnosis and all of that. So thank you so much for your presentations tonight. It's excellent to be here with you tonight. I do have a few questions. I know it's running late, but I want to get to these questions. They're important. There will be a recording if anyone wants to step out now, or if you want to put in any last minute questions, go ahead and do that and we'll see if we can get to them tonight. So thank you everyone for being here. All right, so to get started, I want to start off with some quick, kind of small detail but important questions. When you do cross-linking, do you do both eyes on the same day?
Never, because it creates a 9mm corneal epithelial defect, and people don't like even one of those, much less two of those. That's one reason. The second reason is that for us, we don't put a bandage contact lens. We pressure patch the eye shut. We feel like it's a little bit more comfortable and it's a little safer, so we don't want to have both eyes pressure patch shut. And the third reason, of course, is you don't get paid for doing both eyes in the same day. You can only bill for one eye at a time. So yeah, I don't know anybody who does same day bilateral simultaneous cross-linking, really.
Perfect. And you always start with the worst eye, is that correct?
Almost always. I mean, never say never, but virtually always.
Perfect. And just to reiterate, how long before that haze resolves usually?
Depends on what you mean. The patient usually notices some blur of their vision for about a month. I would say typically at the slit lamp, I can see the cornea hazy for at least 3 months, although I don't think it's visually significant at that point. I've started really paying attention to the amount of haze in my patients after cross-linking. And what I've noticed is as I've meticulously evaluated it and documented it over time, what I started doing is looking to see how hazy the cornea is before cross-linking. And I think keratoconic corneas often, shockingly, are a little hazy before they get cross-linked. I don't know why that is. I don't know if it's activated keratocytes or what, but after cross-linking, the cornea remains to some extent a little hazy forever, but then again, the cornea was a little hazy before the treatment too. So really, it's probably not fair.
Understandable. I do have a question asking about, like, you know, do you have any way of quantifying what percent opacity the cornea usually is ahead of time or after the fact, or if there, like, what difference there is in the opacity?
We do. There's one way that I know of to quantify it very objectively. It's with a metric called corneal densitometry on the Pentacam, and it shows you exactly the amount of backscattered light in the cornea, not only in sort of concentric circles emanating out from the visual axis, but also at different depths of the cornea. You can see whether the haze is present in the anterior cornea. And indeed, you can track that over time if you're so inclined. Every once in a while, I will say probably about 1% of the time, we do develop a patient who has cross-linking who does get significant haze, and we do follow that haze over time with corneal densitometry. So if it perturbs you to see, then you can see yourself and show your patient objective improvement in their haze over time with corneal densitometry on Pentacam.
That's perfect. Thank you. All right. Clark, you talked early on in the presentation about assessing the patient's kind of quality of life and how looking at their refraction just doesn't cut it. How do you kind of assess the patient's kind of quality of life and the impact of keratoconus on that patient?
You know, that honestly is $1 million question. It's sometimes easier to recognize where our limitations are than to try to figure out the workarounds of what needs to be done to define those limitations or to better measure those limitations. So I really do appreciate that question. I think first and foremost, and this is something that I've discussed with some of my very close colleagues who are, you know, who are also very sensitive to these patient needs. I think first and foremost, we don't talk to our patient enough. I feel like it's sort of like going to a therapist's office. It may be as easy as asking how the patient is doing. I think we've all have had patients who see 20/20 again, regular cornea, post-refractive patients, not ectatic, who are extremely unhappy versus patients who are 20, 30, 20, 40 who are actually quite happy. So we know that visual acuity is not always the way to determine how patients are doing and whether or not they're progressing or have certain conditions. So I think, I don't really have a better answer outside of we need to listen to our patients more and be more open to maybe listening to what sounds like criticism from them, because a lot of times I feel like our egos get hurt if they feel like they're not doing well and you're scratching your head thinking, but I got you to 2015, 2020, what more do you really want? I think listening to using aberrometry, for example, again, you could do that with Pentacam, you could use other aberrometer, maybe would better explain why patients are not where you think they are. Listening to how they're reading the chart, if they're reading 2015 or 2020, but it's with extreme caution, that probably tells you that the residual high order aberration there that we have not done done enough of a job to help them reduce that. So there are a lot of different ways, but I do think that just being open and frank with patients and relying on maybe aberrometry and hopefully there'll be other instruments in the future that can help us demystify why some of these patients don't do as well as we think they do.
Perfect. Thank you, Clark. I have a question for both of you. Does a patient being in contact lenses like scleral lenses affect your diagnosis of progression at all?
Yep, it definitely does. But I think it's like what Clark said, you just have to ask the patient, do you feel like you've been getting worse? Do you feel like you're stable? Patients are amazingly able to answer that question helpfully. They really are very useful to talk to the patient and ask them. Often they'll tell you, no, I'm stable. And sometimes they'll say, oh, yes, I've definitely been getting worse. When I take the contacts out, my vision is much worse than it used to be when I would take the contacts out. The other thing is the scleral lens has greater impact on certain corneal parameters, like, for example, steepness, and less of an impact on other corneal parameters, like, for example, thickness. So if the cornea is thinning over time, you really feel like, well, it's not the scleral lens that's to blame. Some of these other factors like steepness, you wonder, but you can mitigate that to some extent by asking the patient to do the same thing every time. Like, for example, if the patient wears a scleral lens, you can tell them, okay, well, I want you to wear your lens to your appointment and take it out, and then we'll take the picture. And that repeated, iterated, gives you a better idea of what's going on than if the patient took their scleral lens out 3 days ago and has now come to their appointment, and you're comparing that to their last picture where their contact lens was taken out 3 minutes before the procedure. So if you do the same thing every time and you're astute, you can kind of get the sense of what's going on.
Yeah, I agree. And extending that principle to doing the same thing every time, I also recapture a baseline, a new baseline, whether it's topography or tomography, every time I change the fit of the lens, because you want to make sure that when they take the lens off, it's the same lens that they've taken off for you to compare with your prior baseline. So anytime I make a significant change, or maybe refitting the patient from hybrid lens to scleral or scleral to something else, you want to make sure that you document very carefully that you're what you're able to use as a comparison going forward. That's number one. Number two, as Dr. Parker had pointed out, the corneal thinning, although, and we could argue whether or not the amount of edema caused corneal thickening potentially, would that kind of throw you off? I think corneal pachymetry, especially global distribution, that ratio is usually maintained. And so it's, that you were relying on metrics more like that or posterior elevation. So I think, again, that sort of goes beyond having topography if you have patients in contact lenses who you're monitoring.
Perfect. Thank you so much. I think we have time for about 2 more questions. This first one is going to be very quick in terms of. All right, perfect. There it is. Do you ever combine cross-linking and wavefront guided PRK?
Never, for 2 reasons. Number one, we don't have PRK, and we don't do PRK for anybody. It's just not the thrust of our practice. Number two, I'm too chicken, which is to say, the point in cross-linking people is that you think, okay, well, this cornea is too weak and it's too thin. And so, combining cross-linking with a procedure that both weakens and thins the cornea, I think is a little bit philosophically dubious, especially because cross-linking has got a 97% success rate, but that means 3 out of 100 people are going to fail. And if the patient, a young person, progresses and maybe they don't come back to their appointment, maybe they don't follow up, but they show up 5 years later and their cornea is 40 diopters steeper, and now they're suing you, and you have to say, Your Honor, the reason I did a medically contraindicated refractive cash pay surgery on this patient with corneal ectasia was, and that is a difficult sentence to finish. So I'm not saying that PRK is a bad thing. I'm not saying that I would discourage a family member from having it, or that anybody doing it on a keratoconic eye is not, doing what they should be doing. But I myself am personally too chicken to do it.
That was an excellent answer. Thank you. All right, final question. It actually has to do with post-surgery ectasia, but instead of being post-LASIK ectasia, it's actually post-cataract surgery ectasia on post-LASIK patients. Do you guys have any kind of either anecdotal feel for it or any studies that you can reference regarding the if there is an increased risk for ectasia on post-cataract surgery patients if they've had prior either LASIK surgery or just in general?
Clark?
I'm trying to think. I'm not aware of any publications that I can think of that points to progression of ectasia, or I assume taking a normal cornea to becoming ectatic after cataract surgery, mainly because the incisions are typically so small and they're more peripheral that even keratoconus patients after cataract surgery, normally they're the state of their cornea is not that affected. So I'm not saying that it's not possible. It's just personally I have not seen that.
Yeah, I agree.
Okay, perfect. Thank you so much for everyone that submitted questions. It's always so useful.
A question really quick to Clark, actually.
Yes,
one question, actually, Clark, you mentioned that you refit your cross-linking patients in contact lenses at 1 month. Do you also give them new glasses at 1 month? And what do you tell them about wearing their existing contact? Do you forbid them from wearing their existing contact after cross-linking? And if so, for how long?
Yeah, that's again an excellent question. No, I don't forbid them wearing their old lenses as long as I know how the lens used to fit. Meaning, if it were a corneal GP that I knew was already bearing, which I try not to fit in that kind of fitting principle anymore. But as long as I can assume that it will be gentle on the cornea. I will let the patient. I would allow the patient to wear the lens sometime after we remove the bandage lens, provided that I see them that day 1 when they're putting back their old lens. And usually, however, I will say that because I'm fitting them in as early as 3 weeks, it provided that their recovery period is very typical, that most patients tell me that, again, beauty of doing one eye at a time is that they still can wear their lens in one eye. And majority of our contact lens keratoconus patients, the disease is so asymmetrical that they're very used to being blurred on one side. I'm not saying that's a good thing, but they're typically, for the most part, not truly binocular, and they function quite well with one eye seeing really well, to be honest. So I will tell you that even though I've offered that option to my patients, saying I'll see you if you want to put your lens back in, say 10 days after or 3 days after we remove your bandage lenses, they usually tell me I'll wait the 3 weeks and I'll come back and reevaluate with you. And meanwhile, I'll just wear the lens that you fit me with in the fellow eye. So that typically is how I go around being able to have patients being functional during that first 3 weeks.
And what about glasses? When do you fit somebody for new glasses?
Yes. So sorry, I forgot. Part 2, glasses, because any type of contact lenses will change their anterior contour as we've discussed before. So I will tell patients that, especially if I know they can tolerate lenses really well prior to cross-linking, meaning I know that they're going to come back to contact lenses after cross-linking, I will defer. That is the one thing that I defer. because the epithelial remodeling, although our contact lenses, especially rigid lenses, will reduce the high order aberration enough that that epithelial remodeling within that first 3 months, it does not affect their prescription as much in the contact lenses. It will have large effect in soft lenses or glasses. So because of that, I will tell them that I need to wait about 3 to 6 months before I would give them a glasses prescription.
Thank you so much.
Perfect. On that note, Dr. Parker, Dr. Chang, thank you both so much for just the sheer amount of knowledge and experience y'all brought to the table today. And I want to thank each and every one of you that attended, sat through this hour and 20 minutes of education just to kind of learn more about keratoconus. Please educate everyone about keratoconus. All right, any last words?
Thank you so much for having me, guys.
Dr. Parker agreed to speak with me.
It's the other way around.
Perfect. On behalf of Oculus and in honor of World Keratoconus Day, have a fantastic night, everyone.